Well done for being back on time, everyone. Welcome to our cooperative members who've joined us for the afternoon session. This is the Adults and Health Committee of Cambridgeshire County Council, and the session this afternoon is on health scrutiny. Just a reminder for those who are joining the meeting, we do allow filming and photography, but please keep your mobile phones on silent or vibrate and don't disrupt the meeting, that we are live streamed and that a recording will be available on the County Council's website. A reminder that at 3:15 we'll have a short member briefing session on health inequalities after the public meeting finishes. Councillor Dr. Nawaz, who's not here yet, has asked a question. He's not here yet, so we'll answer that when he is here. There's no fire alarm test scheduled for today, so if the alarm sounds, I will adjourn the meeting. Straight away, we leave through the side doors on my left, use the fire escape next to the kitchen and make your way to the assembly point in the car park. We very much welcome again our co-opted members from the City and District Council partners who are a key part of this work. And I want to warmly welcome representatives of the urgent and emergency care services in Cambridgeshire who are the subject of this afternoon's scrutiny session. I'd also like to thank I think it was the ambulance services in Huntingdonshire. I'm looking at Councillor Taylor, who can correct me, who hosted a pre-scrutiny visit last week. So thank you very much to you for doing that. The people that we're joined by today at the table are Stacey Coburn, Chief Operating Officer at the Integrated Care Board, Dr. Andrew Anderson, a GP and ICB Clinical Lead for Urgent and Emergency Care, Terry Hicks, the Chief Operating Officer of the East of England Ambulance Trust, and Marika Stevenson, the Executive Lead for Cambridge and Peterborough at E-East. We're hoping that Healthwatch might attend, but they're not at the moment. Their representative isn't in the meeting. Everyone here knows that there's pressure on our urgent and emergency healthcare providers and services, but as always in our health scrutiny function, we aim to be a critical friend and to make questions and to raise issues which are constructive and seek to work with you as our partners to improve the services that are there. Healthwatch is now in the room, I believe. Where are we? Okay. Thank you so much for being along with us. Thank you very much. We now, and that's Sue, by the way, Sue Allen, Head of Engagement, and I will ask you to introduce yourself. Sue Allen, A-L-L-A-N, and I'll ask Sue to introduce herself in a second. In terms of the Huntingdon visit, I want to thank not just Councillor Taylor, but Councillors Blackseat, Horgan, Tevlin and Dr. Nawaz for taking part in that visit. We've had a report which has been provided to us and which is in the agenda pack, and I'm going to ask Stacey and Andrew, Stacey Coburn and Dr. Andrew Anderson, to briefly introduce that report, please.
Thank you, Chair, and thank you for welcoming us.
What you'll find in this room, and I apologise, move the machine as close as possible, and so that the microphone is as close as possible to your mouth. That does help. Thank you.
Perfect. That's much better. I can hear myself as well now. So thank you very much, Chair, and thank you for welcoming us to the committee this afternoon. I will just give a very brief summary. I think probably starting with a bit of national context, I think it is probably helpful to just set the scene for the Cambridge and Peterborough position. So from an NHS perspective, we are expecting the busiest ever winter. We know that through the course of this year so far, we've already seen the highest levels of demand across services, be that ambulance services or our emergency departments, than we've ever seen. Going into this winter, I think we've also been clear from an NHS perspective that we don't have some of the mitigations available to us that we've had in previous years. So last year, you may recall, we were able to open quite a lot of additional beds up and down the country across the health service. Those types of mitigations are therefore limited for us this year. as is the financial context. So, unlike in previous years, this year there has been no additional winter funding made available to the NHS. Rather, it has been a case of looking at our total allocation for the year and understanding how we best deploy that to meet the seasonal changes in demand. We are working within the backdrop of a rising infection rate, as I'm sure colleagues will have seen. The quademic, I think it's now being called. We, of course, still have COVID prevalent in the community, and we're working really hard in supporting population vaccination. But we also have flu, RSV, which affects pediatrics specifically, and also a new strain of norovirus. So we are going into this period, particularly on the back of already challenged urgent and emergency care services, to what is going to be a very difficult winter. In terms of our current performance across Cambridgeshire and Peterborough, there are two key reports I think we've included within our paper. The first is around our A&E 4-hour performance, which is certainly not where we'd want it to be. We have seen improvement year on year, but there is still considerable work to do to ensure that our population are receiving timely, good quality access to urgent care services when they need them. And that also goes for our ambulance response time. And I'm sure colleagues either side of me will elaborate on that a little bit more. But we know that for those that are waiting in our community for an ambulance, they are waiting longer than they should be. Some of that is down to wider system flow problems. Some of that is due to challenges within offloads at the hospitals. But we are working really closely as a whole system to try and understand where the bottlenecks are and what we can do, working differently together to alleviate some of those. We are seeing considerable demand increases. I don't think this is quite as explicit in the paper, but I think it is worth committee understanding. We are seeing about 9% more people attend our urgent and emergency care services this year compared to last year. And most of those individuals are attending via kind of self-presentation. So I think it is worth just noting the kind of backdrop of GP primary care collective action, which we know is also happening, as well as a kind of increasing population demand for urgent care services generally. I think I'll pass to Andrew just to briefly touch on some of the things that we're doing in terms of our approach to managing the risk over winter, if that's all right.
Thanks very much.
Can you move the machine closer to you? It's the only way, the actual whole unit.
Oh,
like
the actual thing. Is that all right?
I think I'm closer again, I'm afraid. Sorry. If you move the machine closer to you.
Oh, yeah.
Okay, go for it.
Thank you. So a lot of my work is in the sort of pre-hospital space. So looking at, and as Stacey says, I think, access to general practice is quite challenged for most patients, with practices running out of capacity, usually around about midday. And then what do patients do? And many of them are turning up at our ED or urgent treatment centres. Our vision or thoughts are that we would prefer people to ring either 111 or 999, depending on the degree of emergency. And at that point, we can try and direct people to the most appropriate service that best meets their needs. So if you ring 999, and Terry might come on to this later with questioning, the call centres are identifying patients who perhaps don't need an ambulance, and they put them in something called access to the stack. That stack is visible to our urgent care hub, and the providers on there will pick people off the ambulance stack. So they will be taking that and dealing with those patients either by visiting or whatever. Once a crew has been dispatched on site, we have another service that's been running for about a year, and we're trying to beef that up now, which is called Call Before Convey. So if there's a patient who's in scope for that service, the crews can ring that clinician, which is usually either an A&E consultant or a senior GP or nurse practitioner, who can often support the crew to safely leave the patient at home or arrange for an alternative place for the patient to be seen other than ED. So that might be referring direct to specialty, for instance, so that you're not sitting in ED waiting to be seen. So those two are working quite well. Figures off the top of my head for Call Before Convey is roughly 70 to 80% of those patients do not end up in A&E, whereas previously they might have done. So I think the ambulance service, like that service, we have recently mandated it for care home residents so that they have to ring before any of those patients are transferred. So it doesn't apply to patients where there's a particular care pathway like strokes, heart attacks, or severe road traffic accidents. The other piece of work is the, excuse me, the urgent care hubs. So we've been directed that we need an urgent care hub. It's clearly a good idea, but there's no money attached to that. So what we've done is we've pulled together a lot of our existing services. So JET, if you know what JET is, it's a joint emergency team. We've got fall services, and the call before convey is all going into that hub. So it'll provide a senior clinical advice line, and it'll provide some community services that can help to deal with patients at home. The idea is that with some of the wraparound services, we can actually keep more people at home and manage them at home, because it's certainly very clear from all the evidence that if frail people end up in hospital for more than a few days, they become more frail whilst you're treating their acute illness. So what we're trying to do is to keep them at home, doing those frailty assessments at home, because at the moment the only way you get them is if you're in hospital. So it's about how we develop those out of hospital services so they're in almost like a virtual ward, and we can go in and do the sort of ward round each day with those patients or manage them virtually. So I think that's a very quick summary of what we're doing at the moment. Further upstream, with integrated urgent care, which is the 111 service, we're looking at how that can support some of the in-hours general practice capacity issues as well. But that's for next year.
Thank you. I'm sure there'll be lots of questions, but I do want to, Alan, just say a few introductory words.
Yeah, sorry, it's my first meeting here, so not quite sure what to expect or what I was kind of expected to bring. So
Yeah, no expectation. You're here and welcome. You're an important partner to this council and this committee. If you want to just listen and respond later, that's fine. Or if you want to make some introductory comments, that's fine. I leave it to you to choose.
yeah, I mean, say I'm Sue Allen. I'm the lead for engagement at Health Watch, and really the only thing I can say at the moment is kind of agree with everything that's just been said as to the information that is coming through to us. Really, all those things that you've mentioned are, things that we hear all the time. Yeah.
Okay, well, we're very pleased again to welcome you here. If you want to indicate at a later point in the meeting, just put your hand up and I'll bring you in at an appropriate moment. But thank you very much for being here. We hope you'll be with us regularly. Right, to our guests, we've prepared our questions carefully, and we've divided them up into four bundles. The first on safety, the second on service delivery models, the third on partnership working, and the fourth on workforce. So we'll take them in those rounds. To members who are not already registered to ask questions, please try and stick to those themes, and then if there's a chance at the end to add in any others, I certainly will. But having said that, let's start with the questions about safety, and Councillor Horgan is the first. Just to give notice, then it's Councillor Taylor, then Councillor Tevlin. Councillor Horgan.
If you could read it out for me, I don't have it in front of me at the moment, I'd be most grateful.
Okay, Councillor Horgan wants us to talk about lack of continuity of care, meaning that carers are effectively project managing treatment on behalf of family members. And as soon as something goes wrong, it creates a block in the whole patient flow. What causes the logjam? So this is particularly sensitivity for carers when they're dealing with urgent and emergency care, and how they're experiencing blockages. What does it look like from your side, and how does that get overcome? Does that do justice to your original thoughts, Councillor Horgan?
Yes, it was based on my own personal experience of my mother earlier this year, so thank you for that.
Thank you. The next one is Councillor Taylor, please.
Again, sorry, Chair, I have seen them and Rashenda has pushed it around, but I have so many here, I cannot find it. I have got my own
I'm
questions,
happy
so
to read it out for you.
please do.
Uh, you expressed concern about the loss of patient-facing time by ambulance crews due to delayed handovers at the hospital. You've not heard that one before, but it's obviously such a continuing concern. That your latest thoughts on how you're trying to minimise the handover time at hospital is what Councillor Taylor wanted to raise. Councillor Tevlin.
Oh, so I would basically like to raise concerns around the entire flow and care pathway from entry point, even from triage on the phone, i.e. 111, through to the ambulance side, and then through entry point at A&E, and then the package of care through to discharge. My concerns around also lived experience, etc., of discharge, where patients are then sort of left hanging and then not followed up with. So that's what I want to raise concern with. Thank you.
Thank you. Just before I bring our guests back in, is there anyone else on issues of safety who wants to ask a question? No, I invite your responses to that first round, please.
Could I just have some clarification on the first question? I don't quite understand the question. So if you could just elaborate slightly on what the concern is, please. Thank you.
Yeah, I've got it in front of me now. Thank you, Chair. Basically, the question was based on my own personal experience of my mother that spent an inordinate amount of time in Addenbrooke's Hospital earlier this year. And she was a complex patient. She was not only old, but she had a number of interacting medical problems, which provided challenges to the medical staff. And she went through, I think, in her 3 months in hospital, she went through 5 different wards. And in each of those wards, there was a rotation of doctors almost on a daily basis, so that every day a new doctor was having to understand what my mum's problems were, diagnose what the latest treatment was going to be, and then someone else would end up having to see it through, etc., etc. And I just felt that this constant churn of doctors in wards was not helping continuity for the patient. So I personally was having to project manage her medical treatment and almost say to argue with doctors to say, why are you doing this? Why aren't you doing that? Etc. etc. I'm not a medical person, by the way, so I'm obviously coming at it as a layperson, but I was finding that too often I was having to educate the doctor as to the intricacies of my mother's complex problems. Basically, she'd suffered with heart problems for many years.
I am going to interrupt there because we had a whole discussion about the relevance of bringing personal cases, and I didn't want to not allow that, but we did agree that we would sort of try and generalise the question rather than become too personal to our experience.
Yeah, I was just basing it on my experience, and so basically the issue I find is, you know, my mother ended up in hospital for much longer than she needed to be, which meant that she was bed blocking, and that it ends up with ambulances being backed up outside A&E because they can't get discharge people out of it. And so is it being looked at about improving the continuity of medical care by not keep changing doctors day in, day out on wards?
So I'll actually respond to that if I may. So thank you for clarifying. I think there are a couple of things to pick up. So firstly, some of the some of the issues that we see with people being moved, particularly between wards and creating an extended length of stay, is partly because we're not getting them to the right place first time. So often when we're working at significantly kind of full capacity, what we're seeing happen from ED is that patients are placed on wards that are perhaps not the best appropriate to care for their needs, which creates additional moves during patients' inpatient stay. So I think our primary focus has to be on making sure that patients are admitted to the right ward first time, because I think picking up all the points that you've raised, that would ensure that individuals are receiving the right care from the right specialists as early as possible in their journey. Now, recognising that, however, isn't always possible. There are a couple of things specifically that are being looked at across the whole of Cambridgeshire and Peterborough to support that continuity, or if not the continuity of the individuals, but the continuity of the storing, the understanding, so that actually patients, but also their relatives and carers don't have to keep repeating what's going on, background history, because that should be and is well within the gift of the providers to understand. So there are two specific things that are happening that are probably worth calling out. So the first is looking at the medical workforce model. So Adam Brooks are looking at their medical workforce model and how they deploy their consultants in particular to focus and work on different wards, and are adopting a consultant of the week model, which means that you do get that continuity for a much longer period of time than currently perhaps happens on some of the rotas. That is not a small undertaking, because to change the medical workforce model, we have to change job plans for individuals across the hospital site. So that is an ongoing piece of work, but certainly something that Adam Brooks, as well as our other hospital sites within Cambridgeshire and Peterborough, recognise is important to support the right length of stay for patients in hospital. The second thing that is being implemented in the most recent weeks is a weekly length of stay review, which is where we have a multidisciplinary team of professionals come together across health and social care, and that includes the ward staff. And we talk through every single patient that has been in hospital for more than 7 days to understand what is happening to their care, what are the barriers to making sure they're receiving the treatment or the diagnostics that they require, and how are we actively planning and supporting them to think about discharge. So those long length of stay reviews that are happening now with MDT, multidisciplinary teams across Adam Brooks Hospital, are happening on a weekly basis and currently have executive level oversight, recognising again the importance of ensuring that we are only keeping people in hospital for as long as they need to be, because they're much better to be at home, supported in the right way in their environment as quickly as possible. So they're two very practical examples that won't entirely solve the counsellors' challenges that you've raised in terms of your personal experience, but certainly I think will go some way towards supporting an improvement in future.
If you continue with the other questions, please.
So I'll pick on the next one regarding ambulance handover delays. And absolutely, that's a very visible part of the patient journey that we see every day. And understandably, it's having an impact on patients, having an impact on staff, having an impact on the wider system, and our ability to get out to our patients in the community. C2 performance is a barometer for patient safety, and there's different parts of the patient journey, from picking up on your point, Councillor, from triage. So from the moment they call either 111 or 999, how do we manage that patient through that journey in the right way? And sometimes a patient will need to go to hospital, but there's an awful lot of work that goes on to prevent them getting to hospital in the first place. But once we get to hospital, how can we make sure that they get through into the ED and seen as quickly as possible? Now, the ED teams are working really hard to make sure that they get their flow, but we do know as well that there are many patients that are in our hospitals that don't necessarily need to be there. So they're fit for discharge, but the back end, the social care, isn't necessarily as reactive and responsive to allow that patient flow to happen as quickly as possible. So there are many points, many bottlenecks in the patient journey that will end up meaning that a patient can't be offloaded from an ambulance in a timely manner. Now, we have a national standard, and that national standard is that every patient should be handed over within 15 minutes. We are significant way off that, and we can see in the report that there are numbers of hours that we lose every single day from delayed handovers. We're working really hard with the collective teams, with the emergency department, the hospital, the wider hospital teams, and the community care teams to implement a transitional period where at 45 minutes we will automatically hand a patient over into the hospital to release a crew to respond back into the community. That's no easy feat, and I don't underestimate the impact that that's going to have for the hospital teams. But we have to make a significant shift change in trying to make sure that we get to our patients as quickly as is reasonably possible, recognizing that there's a lot of work that has to go in behind that. So that's one key element that we're working on at the moment. Regionally, we've implemented that across a number of our other ICS colleagues, but we haven't yet done that across Cambridgeshire and Peterborough. We're looking to do that over the next few weeks. But to do it safely, I think that's really important that we manage to do that.
And then if I can pick up the final question, but if I could ask for some clarification first, that'd be really helpful. So recognizing the concern generally around flow, but you picked up specifically about discharge and being left hanging after discharge. Could you just elaborate on what you mean? Is that once you've been told you can be discharged from a hospital, or is that once you're discharged and at home, potentially without the support, just so I can answer it in the right way?
It's both. As I say, various residents have come to me with experiences where they have been assessed in the wrong way at A&E, given them, though it's like a first line of defence treatment, the treatment was actually completely wrong for the condition. And so upon discharge, they've not been followed up in the right way. It's both in response to what you're asking. I'm asking you. Thanks.
Thank you. That's really helpful. So I think so again, I think there are a couple of different things that we're already doing, some of which are highlighted briefly in the report. But I think the first thing that we've talked about a lot, and we as system partners across the Cambridge and Peterborough talk about all the time, is kind of right person first time, which is no matter what contact point you're using the health service, making sure we've got the most senior, the most appropriate professional available to support triage, diagnosis and intervention. And so some of the interventions that Dr. Anderson described in terms of that urgent emergency care hub, some of the work that we're doing with the ambulance service as well to look at actually, does a person need an ambulance? Do they need an alternative community service? Should support getting people in front of the right clinician first time. ED is very rarely the right place for a lot of people to go, but I think we all recognise that often that feels like the only option for people to receive access. So our focus has got to be on creating suitable alternatives in the community before a crisis point is required for everybody, all but the sickest that absolutely need an emergency department. I think the other piece that we need to and are working through, particularly supported by our voluntary sector colleagues, actually is, so when somebody has then had a hospital episode in particular, how they're followed up post-discharge to ensure that they're receiving, it might be wraparound care, it might just be a check-in to make sure that they've gone home, they're happy with their medication, they know what they're doing. So some just really kind of simple communication with people. Last year, working with the Voluntary Sector Alliance, which is a care network, Caring Together and Age UK collaboration, we launched our Voluntary Sector Alliance, which is a model of care that supports patients on discharge. So over the last 12 months, we've supported 1,200 patients who we felt when they were in hospital might need some follow-up support when they went home. Even if that was just a follow-up check-in, a phone call the day later or 5 days later. We are expanding that service over winter, and so from the 1st of December this year, we will have expanded the capacity significantly within the voluntary sector, and they will be supporting a lot of patients on discharge from hospital to ensure that we're getting that right for people. So I think we've got to get it right first time, but we also need to make sure that we've got services and support in place for people when they do go home if things change, and make sure we're picking those up quickly.
Okay, I think that is the first round. Did any of the three questioners want to come back? No. A couple of points I'll make. One is the 45-minute handover to Terry obviously also has its own risks associated with it, which I think was implicit in what you said. And I think it's important that we get that one on the record. And I think as an authority, I was just confer in there with our executive director. I think we're quite supportive of the principle of the Voluntary Sector Alliance, but it would be good to get some more, because we're obviously very, as an authority, interested in the discharge issues. Be interesting to see more evidence of that, and maybe that's one of the things that we could say to you at this meeting. Councillor Taylor did want to come back on one.
Thank you, Chair. Yes, please. I want to pick up again on the 45 minutes. Will this result in corridor waiting? That is a massive concern. I mean, how does that even work? You know, the department are not ready for the patient. The ambulances are stacking outside. By the way, I'm just going to drop this patient off. I've been here 45 minutes. There you go. It's for you to deal with. Is that patient going to be sitting in a corridor on a bed or in a wheelchair? It's a massive concern.
I think Councillor Taylor has put the point slightly more candidly than I have, but it's the same question. Terry.
Thank you. I absolutely recognise that whatever we're doing is not ideal. However, we have to make sure that we are responding to those patients in the community that have had only a 999 call. So those what we call undifferentiated patients, those have not had a face-to-face assessment. They are the ones at greatest risk. And also recognise that right now we are doing corridor care in our hospitals. So this is not a new phenomena. It is something that we are already doing, and we do it safely. We do it in conjunction with the ED teams. So to almost suggest that we're just going to drop a patient, that's not how the principle of it will. It might sound as though it will, but we will work with the ED teams to make sure those patients that can go into those spaces go into them as safely as possible. But what it will also do is support the ED teams to progress flow through the back end of their department as well, because they know they can see the ambulances coming through the inbound screen. They know how many patients they're going to be getting in the next hour, 45 minutes, so that they can begin to actively plan and then work with the rest of their hospital team to get that flow working better than it probably currently is at the moment.
Thank you. I'm going to bring Councillor Tevlin and Councillor Garvey in. That will be the last in this round. And can I just tell people so that you're aware, Councillor Daunton, Councillor Garvey again, and Councillor Taylor on the round on service delivery models. If you have your questions ready, please. But on this previous batch on safety, Councillor Tevlin wanted to come back.
Thank you. Thank you for your response, especially with regards to the voluntary sector getting involved in all of that. I think that's really helpful. My concern is anyone falling through the cracks, especially when it's patient data, patient records, having a process where there is a handover of those records to these organisations correctly, so no one falls through the gaps and people are safeguarded in that way. Otherwise, I do welcome this. Thank you.
And Councillor Garvey.
I I wondered how well you're getting on with recruiting staff so we can get to the safe staffing levels.
Do you mind if we defer the question about staff to the workforce session? So I'm sure you'll note it, folks, but could you just respond directly to Councillor Tevlin, the first question you heard there?
Yes, thank you. So we've got, there are two things that are in place to try and support that. So one, we've got a shared care record across Cambridgeshire and Peterborough. So this is a system that brings together care records from all health and relevant local authority partners as well, actually, and voluntary sector. And through the lens of direct patient care, we can give access to anybody that's involved in supporting that individual with the individual's consent. So where we can use that, what that helps us to do is make sure that every care professional that is supporting that patient has got access to the same information. So that's something that we've been working through over the last 24 months in terms of implementation. And I'm really pleased to say that from the 1st of December, all of our voluntary sector organisations also add access to that. The second thing that we've got is we do have a shared function. So we have a shared operational delivery function that works together on a day-to-day basis, which has colleagues from all of the relevant organisations. They work together all day, every day, speak about the individuals they're supporting. So even if we're not picking it up in written notes, again, and an awareness and knowledge of those individuals that we're supporting, they're able to work together in an integrated way to support those individuals. So again, absolutely recognise there's always a risk of not every individual being picked up in all of these, but certainly we've got some mechanisms in place to try and support that as to be as effective as possible.
Thank you. We now move to a section of questions based on service delivery models, and Councillor Daunton is the first questioner, please.
I hope I've remembered my question correctly, Chair, but I'll put it anyway. So I'm concerned about A&E, the experience in A&E, and I know that staff work very hard in A&E. I think what I'd like to know is, how do you think that the service, the experience of the user of A&E could be improved? So one turns up in A&E anxious, scared, terrified, disoriented, and then is told to wait 6 hours or 9 hours. And one has no agency over that. Why are we waiting? What do you think could be done to improve and help that experience? Would it be greater information? Would it be better surroundings? Would it be a bit more hand-holding if there was the possibility of that? What could be done to make that experience more bearable?
Thank you. Councillor Garvey.
Richard?
Oh, okay. I can ask you on your behalf. Can we have Councillor, sorry, there's one other, and I want to make sure I get it right. Councillor Taylor in this session. This is on service delivery models.
Yeah, thank you, Chair. I think I have found my question. So mine was to do about the frailty service. I just want to understand that a little bit more. And also, I want to pick up on, so we're looking, you just spoke about call to convey, and now you're looking at that within care homes. So the ambulance service calls to care homes, the frailty service, and now the call before convey, and how that all links in. And when you are now looking at call to convey in care homes, how is that working? And how do you know the outcome if you're going to leave a care home resident there, if the outcome's going to be a positive?
Thank you. Also, please stick to service delivery models. Councillor Seif.
Thank you very much. My question concerns response times of ambulances, and I'm looking at the table that we have in paper 14A or B, and I can't remember, and we see that response times in all the categories that is more extended in 2024 than 23. You've given us averages and statistics, lies, damn lies, and statistics. In a way, because this is about people's personal experiences, I would really like to see almost the range, the best and the worst. Clearly, on C1, it has to be pretty precise. I suspect as you get into the other areas, it's a little wider, the range. And I guess my question really boils down to something that I discussed briefly with Mr. Hicks last week, where he told me, when I asked the question, how much downtime is there with the ambulances? And you gave me a very surprising statistic, 40%. Clearly, something is being done about it. You're talking about an additional number of vehicles, 228 coming in, and there's other measures to improve that performance. But I guess my question is, first of all, has downtime caused some of the problems in those stats that we've seen? In other words, extended response times. And what sort of problems have they caused in a way? Will it get worse until it gets better? How long will it be until you can get down to the target, which again, you were kind enough to, I'm not challenging you. I know this is a very, very difficult job, but I know you want to get down to 20% downtime. How long do you think that will take, given the measures you've proposed here?
I bet you've not been asked that question before, Terry. I'm going to add one in this section, which is specifically about the point in the report that you kindly prepared for us about changing the triage to using 111 rather than face-to-face triage at the emergency department entrance, which is obviously quite a significant change. I'm just checking I've got your attention. It's obviously quite a significant change, and then using technology, as you call it, to link up. From a patient's perspective, the idea that you get to speak to someone through technology rather than face to face, if you're in an emergency situation, doesn't necessarily sound that attractive. I'm sure you'll understand. And also, I think if one attends the emergency department, you're assuming that when you see someone, you're seeing a medically skilled person, and that if you're in an emergency, you'll get the help you need as quickly as you need it. We've all got experience of 111 where you're not speaking with medically qualified people, and it can sometimes take several hours and 3 or 4 phone calls before you actually get to speak to someone, and the people that you speak to are reading off lists of questions on a screen in front of them rather than applying any clinical knowledge. So it does seem a bad deal from the point of view of the patient, but we're willing to be persuaded otherwise. But please do say how the service can still be personalised. And then if one attends the emergency department, for example, Adam Brooks, and the triage says that you're not eligible to go to the emergency department at Adam Brooks, but you're eligible to go to the alternative hub at Sawston, how are you supposed to get to Sawston? And how would you reassure patients in Cambridge, which is a huge population centre, that they're not just going to be deterred from getting access to emergency help by being referred to this alternative and obviously less convenient hub? I invite you to answer the questions you've heard.
So I'm going to take most of these, I think. If we perhaps do the 111 piece first, if that's okay. So I would prefer everybody not to just turn up at urgent treatment centres and ED without ringing first, as I've said earlier on. So if you ring 111, we don't have enough clinicians to answer the volume of calls, so we have to have a sieve, and that's what they use, a pathways tool, which are non-clinicians, as you quite rightly say. At the moment, it is risk averse. I think we all recognise that. And Cambridge and Peterborough have been at the forefront of remodelling how 111 works. We were the first call centre to put GPs in the call centre, who were checking the ED outputs and the ambulance outputs from 111. We were getting GPs to check those, and what we found was 80% of those people did not need to go to A&E, 80% did not need an ambulance sending. That very quickly became nationally mandated, but we invented it here. We did it here first, and so that's what happens at 111. I would love them to check all of the calls, but at the moment we're checking about 50% of them, and that's about capacity and staffing issues and money at the end of the day, as to what can we afford to do. I think that makes a huge difference in terms of making sure that only ambulances are sent to people who are assessed as really needing an ambulance. So that's the 111 bit. I think the bit about the 111 at the front door, which we are going to start doing, we did it at Hinchinbrook about 2 years ago. I thought we would get a lot of patient pushback, and amazingly we didn't. And I think the reason was that we gave those people, it was a face-to-face thing, it wasn't people doing something online. We had a nurse in there using the 111 algorithm to redirect people to an alternative service that best met their needs. And what we were doing is we were booking them appointments with GP practices, and they were quite happy to go back to their GP practice knowing they got a definite appointment. And because I thought this is going to fail, we piloted it. Patients are going to hate this, and that's what I sense we all probably think here. But actually, they didn't. There was very little animosity to that sort of service. So it worked in Huntingdon, which is a far more rural area than the city of Cambridge. So we just need to make sure we've got that where we're redirecting them is a convenient place for them to go. Now, a lot of them will be redirected, I suspect, to the urgent treatment centre, which is just 20 yards down the road from ED. It's on the same site, which is one of the arguments for the co-location from a few years ago. So no one's going to be made to go somewhere that they're not happy with. With all 111 stuff, patients can refuse the disposition, and then it goes to, well, what's the next most convenient service? And it will probably be the UTC. But if they're happy to accept an appointment at their GP surgery, we can book one for them. They may choose to accept that as well. So that's the 111 piece at the front door and 111 in general. ED experience, up until last year, I did out-of-hours shifts, and I regularly turned up at Adam Brooks and Peterborough to do my shift. We were co-located, and it's not a nice place to be. It is overcrowded. There's people waiting around, and a lot of the people are frail elderly waiting for a bed upstairs, and there's no room at the inn. But then there's a lot of people who are the walking wounded that come through the front door. They're the people I want to ring first, and we can get them an appointment in AD. So for 2 years, I've been championing appointments in ED. There's been quite a lot of resistance from ED colleagues because they're not used to working in that way, but I sense there's a change now in that outlook towards appointments. So if you fall over and you think, oh, I think I might have broken my wrist, it's not time critical, but you probably need to be seen today. And it's, what is it now, 3 o'clock. And we can give you an appointment at 5 o'clock. You haven't got to go now and sit and wait for 2 hours. You can go at 5 o'clock and you'll be seen at 5 o'clock. Now, I think that's a much more convenient service for patients. We're not there yet. We've got some way to go. Some things are time critical, but once we've assessed it, maybe, yeah, you need to go straight away. So there'll still be that walk-in element, but I'm trying to move A&E more to a booked appointment service for some things that are not time critical, because I think that's a much better patient experience. It allows ED to even out their peaks and flows that they get throughout the day. So that's something that we are working on. It's not, I mean, we can book appointments now in the UTC, but we are working on improving the ED experience. And for the booked appointments, this is tongue in cheek, by the way, I want a really posh waiting room where you can sit and wait and you'll be seen straight away. And the people who just turn up will, how come he's come and he's got an appointment straight away? I want them to ask the receptionist, well, they've rung 111 and they've got an appointment, and that's called experiential learning. So those patients think, actually, rather than me just turning up next time, I might ring 111. And 111 will be able to book you into a service, but it might not be ED. It might be a service that best meets your needs. Because we've been trying to get people not to just turn up for years. It doesn't work, you know? And we need to just think a bit out of the box in a way in terms of how can we make some of those alternatives more convenient for people, because people will go where there's the least resistance. So that's the ED experience piece. Frailty, we've got the frailty service. At the moment, it's mainly looking at people who have been admitted to hospital with frailty, and doing what they do in terms of rehab and trying to address the frailty. That service is going to come out to be formed part of the hub work. So if we identify people that we're keeping in the community who are frail, they will still have access to that frailty service and all that they can offer in terms of rehab and trying to minimise frailty. The other thing I can go on about with frailty, which I'd like to mention today, is that's the people who are already frail. But what about, I'm one of the ones in this room, I'm going to be frail in 10 years' time, I suspect. How are you going to stop me getting frail? And what's the plan? And that's where I think, as a partnership with the local authority, it's how we improve access to exercise and swimming and all things like that to the community, which is affordable for people. Because I can afford gym membership, but a lot of people can't, you know. So it's how do we encourage as a community and society to encourage the next generation of frail people, which, as I say, me and probably a few others in the room, you know, what are we going to do? How are we going to try and keep people as healthy and strong as long as we possibly can? And health can't deliver all that on our own. It has to be a whole societal thing that I think we need to just look at. When we retire, what we mustn't do is sit down and do nothing, because that's the worst thing you can do. And I'll segue into Terry. As I say, I've spoken about 111 checking the ambulance dispositions. And if we're doing that, 80% of those don't need an ambulance. But then, Terry, what do you do next?
Thank you. Just picking up on the point about call before convey and care homes. So call before convey is a service where we have automatically dispatched an ambulance. It's then when our crews are on scene to be able to call into expert clinical advice to understand if there is a different output and outcome for that patient other than ED. Where we've mandated that for all care homes, we were finding that patients were being taken into hospital unnecessarily where their care could have been seen by a community partner, urgent community response, but we weren't doing that. So mandating it for care homes means that for all patients that we see in a care home, we can call before convey during their hours of operation and seek an alternative. We might not get to that alternative, but it means then that patient might have a different output other than going to ED, and they can be safely cared for within that care home setting. So, excuse me. So we've seen it's been in operation for about 3 or 4 weeks now. We've seen some increase in call times for call before convey because there's an increased complexity of those patients that they're having to deal with on the phone. But we're also finding we're reducing the avoidable attendances for those frail elderly patients going into ED, who then automatically will become admitted. They'll have an extended length of stay. So they're staying in their place of home. So that's got to be really important for us to be able to do that. Coming to Councillor's point in terms of our vehicle availability, yes, we have an incredibly high, nationally high service level at 40%, working really hard over the last 12 months to reduce that down, and our aim is to get that to 20%. We're partway through a program of replacements and growth vehicles. So that's going to take about 18 months to fully come through in terms of getting all the additional vehicles in, replacing the aging vehicles. So I would expect to see between now and 18 months' time, we will significantly reduce the vehicle off-road, the VOR rates come down to that 20% and then remain consistently at that 20%. We've got an aging fleet at the moment. They do a lot of miles, so they are going to get they're going to get those issues that come up when you've got an old vehicle. They start failing more often. And whilst we have crews available, they might not have a vehicle. So undoubtedly, it will be impacting on our ability to respond to our patients. But we work really hard with our make-ready teams, as you will have seen last week, to get those vehicles back into service as quickly as possible. We use a variety of internal workshops, external agencies that come in and fix our vehicles in our garages or on the roadside. So we're doing a lot of work, but it's not, unfortunately, it's going to happen overnight. It's going to take a little bit of time whilst we work through replacing those vehicles.
Can I just come in on another thing I just thought of with call before convey? One of the advantages is that service takes ownership of the patient journey and will sort out the onward referral. So we do provide that service into South Lincolnshire, and they've actually done some data for me which shows that their time on scene is reduced in the areas that we serve compared to the rest of Lincolnshire. So I suspect it'll be similar for C&P. We just haven't done the figures yet, but crews spend significantly less time on scene, so that means they can get to the next call, because call before convey is now managing that patient journey for them, which might be people arranging their own transport to that service as well, rather than the ambulance. So just because an ambulance is there, it doesn't mean an ambulance needs to take them. If it's a child, the parents could take them in the car safely, but that's all part of the assessment. That then frees up the ambulance rather than going to ED and then perhaps waiting in a queue for the 45 minutes to come. It's actually then the patients can go directly themselves, which again is often more convenient, I think, isn't it?
Okay, Councillor Garvey.
Thank you for giving me.
Can you talk directly into the microphone?
Thank you for giving me the questions that I'd asked. I think they've mostly been answered, which is great. And I suppose one of them that was what criteria is used to decide that a person needs to be admitted to hospital, and can that be tweaked so less people are admitted?
So that's exactly what we're doing in the pre-hospital space. I don't even want these people to get near the hospital. I want that assessment to happen in their own home with the right professionals, the right clinicians, and the default should be, does this patient treatment package mean we can deliver it at home? And if we can, I think we should strive to do that. Now, occasionally people will have to go to hospital, usually for diagnostics, so they might need a scan or an X-ray or blood test, which is not so easy to do at home. So those people might need to have that assessment in hospital. And then again, once that assessment takes place in hospital, we're working with colleagues to think, please think about home first. You know, can this patient come out? We've started to develop virtual wards in the pre-hospital space. We've got virtual wards in the post-hospital space. So from A&E, they could discharge to home into like a virtual ward, and they will technically still be under the control of the hospital consultants at that point for that specialism. So that's the post-hospital virtual ward, but we're actually pulling them into that pre-hospital space as well. So the key message is try and get those assessments done at home. If the most appropriate care can be delivered at home, that's what we're going to do. If they need to go to hospital for diagnostics, that will be done at hospital, obviously. But again, the default should be, can this patient go straight home? Do they need to go into a hospital bed? And have we got the sort of virtual ward scenario and the capacity to look after this patient safely at home? Mm-hmm. And if we can do that, we will. I think people will remain more able if they're at home, because they'll have to get up to go to the toilet. They'll have to walk with some support from people. Because in hospital, and again, I know we shouldn't go into personal things, but you know, my mother-in-law, they kept still in bed at 3 o'clock in the afternoon, bringing the bedpan to her. Well, who's going to do that at home? Because she needs to be able to walk to the toilet. So, and I understand why the nurses don't do that. It's because it's time. It takes a lot longer to get that frail elderly person to walk to the toilet and back to the bed than it does to just give them a bedpan, because that's quick and easy, and then they get on to the next patient. So it's about capacity to that. But at home, you've almost got to do that. So it keeps you more able. And I think most of the patients would prefer it. They don't. Most old patients actually don't want to go into hospital. Please don't send me to hospital. So we need to look at how we manage them at home safely. Thank you.
The only thing I'd add on that section is the questions put by councillors about the new mandated policy on care homes. I think it's probably reasonable for us to say, you know, review it, have scrutinise it, show us the evidence that it's working well. So I'll just add that. Right, the next round is on partnership working, and Councillor van der Ven will be the first questioner, please. Then it'll be Councillor Taylor.
Thank you. And I recognize you're 4 individuals representing an enormously challenging area of of our health service. So thank you. My question is about coordinating responsibility. I'm most interested in responsibility between primary care, ambulance, and hospital. I get the sense that the ICB has a coordinating role, but if you could provide some clarity on that. And I think the shared, sorry, what's it called? The national shared care, well, I'm not going to get this right. The shared care record is important, but is it enough? Is it working in that experience? And I'm going to extend my question to a part 2, inspired by all that Dr. Anderson especially has said around, please don't come to the hospital if you don't need to, and all the initiatives around avoiding hospital admission. And I hope, yeah, that is all very encouraging to hear. We talk about avoiding admission at A&E and why. And we talk about, you talked about pressures on GP practices and the fact that they get full up, and then in the afternoon they might seek help elsewhere. So I guess if we're cascading down, there's also an avoidable admissions question at GP practices. And I realize that's a bit off topic, sort of, in a direct sense, except except that it seems part of the picture. And I know the ICB is very concerned about primary care and trying to support it. But when you look at the picture of urgent and emergency care and avoidable hospital admissions, in your work, do you also actively try and address that question of GP capacity and also avoidable GP admission? Sorry, that was a bit cheeky.
It was a bit cheeky, but that's democracy. Councillor Taylor.
Thank you, Chair. I'd still have to get used to having all the questions at once. Right. Hey, speak for yourself.
That was very insulting to Councillor Taylor, but I'll let you get away with it.
Okay, so I'm going to talk about education. I think it's really important that residents are educated on when to call an ambulance and when not to. Now, as we're talking about partnership working, is this something we can work on? I don't know, public health and something like that. I know we've gone through spats of it before, you know, letting people know when it's really important to call that ambulance. And as well, it's always a worry that when people do, and sometimes it's the older generation that need to and don't. And that is a real concern. And also I've got another one on partnership working. So there is a trial within the fire service in Huntingdonshire with the community welfare officers. Now, this wasn't actually in any of the papers, so I'm hoping that you are aware of it. Among other things, they do self and well visits, but they also attend 192 calls. I think, I can't remember when that was over. I haven't written it down. But they have attended 192 calls for East, ranging from falls, seizures, cardiac arrests with CPR, which equates to 1,443 hours of cover. I've got other statistics there, but so basically it's the lowest response time. So there's different trials over the 4 counties undertaking the trials. So I just want to understand your understanding of this trial that's happening as well.
Please.
Thank you. So if I pick up the first 2 councillors' questions, so on coordinating responsibility and the role of the ICB, absolutely. We are one of the many partners that sit around the table, but one of our responsibilities is about how we bring together all of the different providers and commissioners to make sure that we're getting the best for our population collectively. And I think on the interface between primary care, the acute hospitals and the ambulance service, that is an area where I think actually our conversations are quite mature. So as a Cambridgeshire and Peterborough locality, we've had what we call unplanned care board meetings that have happened monthly for the past 2.5 years, where we come together as senior officers from all of the respective organisations to talk about where our pressures are, where our risks are, and how do we work together to implement either different models of care, to improve patient safety, to improve experience. That also happens, of course, in a whole range of other forums, ICB board and others, where we have all partners around the table. So I think we are really actively working together to look at urgent emergency care. And it is only by doing that together we're going to solve some of the bottlenecks rather than just move them. And I think what we've heard today is, you know, there are multiple bottlenecks across different parts of provision. And what we're trying to do systematically is understand what's driving them and what does a fundamental different model of care need to look like for the future. Because I think what we're really good at doing in health is actually just layering on services or changes to solve that one particular issue. We don't always have the opportunity, given the pressure, to step back and think about actually a very different model of care. And that, I guess, links into the second councillor's question around, I guess, engagement, population, education, and how we work with the general population around use of health services. And forgive those that sit at the integrated care partnership, but I know it's a conversation we've had there. I think we all recognise that unless we start to prevent risk, so unless we start to think about how we engage people who have long-term conditions or who have rising risk as they grow older, become much more complex, unless we engage people much earlier in those diagnosis and management of condition, we're not going to prevent the rising risk that we're seeing. And given population growth, that is going to be a real challenge for us collectively. So we have got to start thinking about prevention in a way that we haven't done before, which is absolutely about education, but actually making sure we're providing then a level of service to people whilst they're kind of earlier in any diagnosis, that we're putting the right support in place, as Dr. Anderson said, not just a health intervention, but a more holistic societal intervention to ensure that they are able to stay well. And actually things like our place and our integrated neighbourhood teams are critical to how we deliver that in future. We are also really focused on the here and now, as I said. So we're definitely working on new care models, thinking about what we need to do for the future. But certainly in terms of the education with the population, I think one of our reflections would be we can ask people to go to other services, but it's really difficult if you're not a clinician or if you don't work in the NHS. And even if I'm honest, sometimes we struggle to understand where best to access. So I think our ethos has got to be, or has led to, we need to do the work behind the scenes to make sure that we're putting the right people in front of the patients who are seeking care and not asking the public necessarily to be able to make that distinction. Because often, actually, if you are quite sick and you are quite unwell and you're quite worried, it's quite an anxious time, we need to make sure that there's no wrong front door. And whatever door you do seek care through, we are still able to make sure that you receive the care that you need in the way that you need it and as described. So absolutely support Dr. Anderson's. We should all ring 111 first unless you definitely need an ambulance, which is absolutely right. But we can't take that view in isolation of making sure we've got a no wrong front door policy for our population, because we know that despite population health and a lot of engagement, changing people's behaviours, particularly in periods of anxiety, is really difficult.
I'll pick up on the piece, if I can, on fire and rescue service community welfare officers. So we've a number of schemes across the organisation. And we use routinely community volunteers. So we have community first responders working across all of our areas. And they are lay people with training to use a defibrillator, to use oxygen. The principle being that if you're having a heart attack and in cardiac arrest, the quicker we can get somebody trained with a defibrillator and oxygen, then the better your chances of survival. So we have a lot of schemes across the organisation and across Cambridgeshire and Peterborough, which includes military co-responders. So we have a team that operates out of RAF Witton, also teams a little bit further afield, RAF Marham, RAF Henlow, Honington. So very good relationships with our community providers, our community partners. But from a fire and rescue service perspective, an incredibly good relationship across Cambridgeshire and Peterborough, where we utilise their retained teams to respond to cardiac arrests for us. We train them, we support them with their welfare post cardiac arrest, but also to make that ongoing care for them as individuals. So the community welfare officer was a scheme that was introduced last year that operates across not just Cambridgeshire and Peterborough, but Bedfordshire piloted it first, and a very good impacts from that. And you're right, they'll go into patients' home as part of their daily routine work, but they can identify, they can adapt, they can signpost that individual to other avenues, but they're also available if they are closest to a cardiac arrest. So we're able to track them, we know where they are. They can also respond when we need them to. They could turn around and say they're not available at that point, but they predominantly they make themselves available. They recognise that they are providing a really good community service and to save a life, and that's what we're all about. How can we save a life and make sure that we've got as many resources? They will always be backed up by a trained clinician, so an ambulance, and we'll always make sure that in the same way that we do the retained teams, that they've got support behind them if they do go to cardiac arrest, because it's recognised not their normal day job. So very good impact from our community response teams that aren't necessarily paid by us, but work on behalf of us.
We're nearly at time, but I've got one more question on workforce. We've already heard a question from Councillor Garvey, which I asked you to deal with in this later section. But can I take this one final question from Councillor Taylor, please?
Thank you, Chair, and so sorry for all the questions. So I just want to know what's been done to address the workforce burnout, both within the acute trust in the county and by the ambulance service. We hear a lot about how exhausted the staff members are within the whole NHS. So they work long hours. So I would just like to understand that. Thank you.
And obviously, it's a big issue. I'll ask you to focus particularly on the emergency departments and the ambulance service. So you give us a real snapshot of what that's like on the ground and what you're trying to do on the ground.
Thank you. I mean, there's no denying that working in emergency and urgent care is an incredibly difficult role. And we train our teams as best as that we can. But they do, you're right, they do work incredibly long hours. They drive hundreds of miles to get to their next patients. Very little often downtime that they get during a shift, because there'll always be a patient waiting. And we have to understand that sometimes we can't just keep our crews going. If they're late off and if they have a late job, we can't just, they won't just stop with their patient. They'll see that patient through to close of their case. And sometimes that means they're late off. And often they can be late off by 2 hours, 3 hours, which means they've done what was a 12-hour shift is now a 14, 15-hour shift. So we will allow them the following day, if they're coming back into work, to have what's called compensatory rest. So we don't expect them to come in on time for the next day. We will allow them to manage their hours in that respect. That's not always possible. We can't always do that, but there is a process that we do that. From driving regulations perspective, particularly at night, it's very difficult. Driving at night and under emergency conditions can become incredibly challenging. So the crews themselves, where they can, they will alternate driving, so that it's not one person driving all the time. Doesn't always work. Some might have longer journey times than others, but generally we try and share the workload out. And also we have we'd like to think we have an open door and a route back to our local managers to support the crews if they are struggling, if they are getting tired, if they're getting burnout. We can look at alternate roles for them. That means they're not always on the front line and they're maybe doing an alternate role, but still within the service. But again, we can't create a role, and those roles aren't always readily available. But there is no denying that it's a tough role out there. And over the last 18 months, we've done a real strong piece of recruitment to make sure that we can upskill our staff and get the right numbers of staff in. So this time last year, we had, I think it was an 18% vacancy rate, particularly in Cambridge. And our recruitment teams have worked very hard to fill that gap, to such an extent now that we are over-established in all three of my hub areas. We don't necessarily have the skill within that, but we're training our staff. We give them the basic level of training, and we keep training them through the course of the year, offering them extended training to move to the next clinical grade. So we're doing that all the time. But I'm pleased to say that we are, as I say, over-established. So we've got our staffing profile now is probably the best that it's been, I would say, for probably 10 years. Our next step is to make sure that those staff are as trained and as well cared for, and they have the right level of well-being support in place to them to make sure that they can continue coming to work effectively, consistently, to deal with our patients.
And I'll very briefly talk about the emergency department. So I can't actually speak on behalf of the hospitals, as they were doing a huge amount themselves as organisations to support their workforce. But similarly to what Terry's outlined for the ambulance service, we've got wellbeing hubs, we've got a significant amount of roles within all of the acute providers to support individuals that are working in urgent and emergency care. We have also invested heavily in urgent and emergency care over recent years, and that is predominantly in workforce. So from a system perspective, there's been about an extra £34 million that has gone into urgent and emergency care over the last 2 years. And that is about making sure we've got the right skill mix, the right level of capacity available, so that actually, these are tough jobs, but we can't and don't want to be making them tougher than they should be due to gaps in staffing. We've also looked quite a lot at auxiliary roles. So what support do the clinicians need to enable them to operate in the most effective way? And often that can be simple things around, IT or kit or easy access to a coffee when they do get a break. So I know that certainly at all of our providers, they've looked at what are some of those wider opportunities to improving staff experience overall, which just make, sometimes it's the smallest things that make the biggest challenge actually after a really difficult shift. So we need to be taking care of the little things as well as just making sure that we've got the right workforce at the right time.
We have reached time. One comment from me, and then I'm going to attempt to summarise the main conclusions. The comment is this. I think, Stacey, you were talking about the importance of partnership working, dealing with all of these complex factors together, and we couldn't agree more. And we look carefully, obviously, at hospital discharge. That's a big role that the local authority's got a role in. And I know how closely cases are analysed, the systems, including escalation, that exist to deal with that, where we've analysed longer term cases and what we do to deal with that. But I sometimes, when I listen to sessions like this, and not wishing to be critical, but it's just portrayed as being numbers, not people, and the problem is that people are blocking, and it's not talking about the welfare of those people. And the hospital discharge people that the local authority have quite rightly put the welfare of the people that are there first, and that will sometimes mean that there's a delay in discharge because it's not the right outcome for them. And I think there are many of our health colleagues that agree with that. But the MP went into one of the local hospitals recently, and all they did was criticise the local authority over hospital discharge. That was really disappointing. And I think we've got to have a grown-up conversation about that, recognising the joint difficulties and putting emphasis on the outcomes for the people that are there in the hospital, not just on seeing them as numbers, trying to get the flow quickly. I could see you want to come back, so I'm going to enable you to do so.
Thank you. So the first thing I'd say is that from an ICB and from a partner perspective, absolutely people are at the centre of what we do, and we should be prioritising individual experience and quality of care, whether that's healthcare or social care. I find that really disappointing that that's the feedback that colleagues have had, because I think on a practical level, our teams are working together excellently on a daily basis. We have a shared transfer of care hub where our health and local authority colleagues work together on a daily basis to try and do the best thing for people. And ultimately, there will always be scenarios where there are difficulties, particularly where we've got complex patients. But certainly my expectation of my teams involved in that are that we put the person first and we can sort out the rest behind the scenes. So I think my commitment is absolutely to that approach. And I think you're right, we just need to be able to have the honest conversations if we feel that we're not seeing that from any partner that's around the table, and that we're doing the right thing for the person in the first instance. And I think our transfer of care hub do demonstrate that really well. And I think certainly even some of the work that we've done recently, that we've talked about the integrated care partnership, like the Better Care Fund review, has been done collaboratively with all partners, because that's the only way that we can make the improvements that we want for our population.
Good, you said that today. I hope you'll feed it back as well. As ever, what we do, this is the process. I quickly summarise what I've heard, which is an imperfect summary, and then afterwards, Rashendra and I our Democratic Services Officer get together and we create a formal record. But I think we've noted that this is going to be the busiest ever winter for urgent emergency care. I think we support efforts we've heard about to get patients to go to the right ward first time to avoid discontinuities in care. I think we recognise the continuing delays in patient handover and that national standards are significantly not being made. But we've heard and note efforts towards the automatic 45-minute handover time. But we've also discussed and draw attention to risks with this practice. I think we recognise probably and support, we'll see what other members say, the need to create safe alternative pathways as one option for emergency department attendance. I think we probably commend efforts towards the Voluntary Sector Alliance to improve the experience of hospital discharge. But we do ask for more evidence of its effectiveness. I think we encourage efforts to improve user experience through better information, a better environment and support to patients themselves. I think we probably expressed concerns about the new mandation of calls for urgent emergency care for people in care homes, and that may impact outcomes. And we call for full scrutiny of that new policy. I think we recognise efforts to get people to ring first rather than attend the emergency department first, but note that only 50% of calls to 111 are checked by medically qualified staff. But we do note the experience at Hinchinbrook Hospital that a face-to-face service was provided to offer alternative provision, and that redirection when it's brought in elsewhere is going to be to an alternative convenient to and acceptable to the patient. We support efforts to introduce timed appointments in emergency departments, Dr. Anderson was talking about, and the benefits that this can bring to the patient experience as well as to the flow in emergency departments, and recognise that this may also positively contribute to behavioural change to encourage people to call first rather than just turn up. I think we would commend efforts towards partnership working with local authority and prevention efforts towards people living with frailty. And on that last point, also in the same context, support the person first principle, which includes ensuring the appropriate social care in relation to hospital discharge. We would welcome plans to replenish ambulance service vehicles, and note that this will allow targets for the downtime of vehicles to be achieved within 18 months, it is hoped. Commend efforts of the community welfare team in Huntingdonshire, and it is a pilot that's being spread, and believe that such a service can help save lives. That we recognise the importance to undertake, we've done that one, we agree that no wrong first door policy should be maintained, and that education encouragement should be used to encourage calling first. And on the workforce issues, we support arrangements for compensatory rest where staff have worked excessively long efforts. Note efforts to drive down, I'm going to say successful efforts to drive down vacancy rates. And encourage efforts for local managers to be responsive to staff experiencing workforce stress and to improve the staff experience overall. That was an imperfect summary, but we had a very rich set of exchanges, and I hope it does at least some justice to what we've said. And the purpose of creating a full record of recommendations is to help you. You know, I think you saw there were lots of encourages and supports and recognises in that, not just criticises. And hopefully this will be good food for thought for you and your colleagues. You've given us lots of food for thought today, and I'd like to place on records my warm thanks to all 4 colleagues who've been with us to attend this session. So I'm going to move forward seamlessly for members. I think on the open part of the agenda, I just have to go to my note, which is the work programme and the recommendations tracker. Do any members want to make any, thank you again to our guests, any members want to make comments on the work programme or recommendations tracker? No. In which case I close the meeting, but we move seamlessly into a continuing informal session, development session, where we will be preparing for the work that we're doing. Have I missed something? Okay, so it's okay because I can see that